I'm going to start the return to play on groin injury, and there will be more groin injuries after me. So I was given the task of talking more about the long-standing ones. And I will touch upon three things. We're going to discuss whether RTP is relevant when we're talking about long-standing hip and groin pain. We're going to talk about what are the challenges in this area, and also what do we actually know on RTP in relation to these injuries. I think this is a very nice and old model, and it's very true when you come to overuse injuries, because this shows a different road than the one we showed before, but it's also a road that shows that if we want to determine return to play in somebody who has an overuse injury, it becomes very difficult because their injury has already started and their pain has started in some way here, and maybe they decide to get out of the game here first. And then they might even decide to get back into the game, but then they get to problems and then they have to get out of the game. So I think with these overuse injuries, you can see how difficult it becomes to try and measure return to play in a situation like this. When we are looking at the data in the literature, it's very problematic, because mainly what we know a lot about is groin injury incidence, and we usually describe that as the tip of the iceberg. And we know in soccer, for instance, that at the elite level it's around 20 players, so at the Champions League level, 20% of players will be affected by time loss related to hip and groin problems. At the sub-elite level it seems less, around 5%. So you could probably argue that it's, depending on what level you're at, it's definitely at the sub-elite level it's not a very big problem. It doesn't constitute a lot of problems. And if you look at the elite level, you can also see that 90% of those who actually get a groin injury only have it for less than, or they don't have it, but they're back within 4 weeks. So again, you could argue this is not a problem. They're really fast back. I think everyone who's been in this room and treated these patients would say that doesn't really fit with your picture of whether this is a problem or not, or how big the problem is. So there's a huge part of the iceberg that we don't know anything about, and it's mainly to do how we described it in the literature. So we did a study in Denmark where we investigated the prevalence of hip and groin pain in male adult soccer at the sub-elite level, and we wanted to explore the association between hip and groin pain prevalence and also the duration of pain, and related to the Copenhagen Hip and Groin Pain Outcome Score. And what we did was we had 6 persons attending training sessions in the beginning of the new season in 40 clubs, and that they came out to almost 700 players, and we got self-reported hip and groin pain history from the previous season, and also we had information on Hagers from in the beginning of the new season. And this was done during the first 6 weeks of the new season. What we saw was that when you ask soccer players whether they had hip and groin pain in the previous season, 50% would say yes. And that's probably not so surprising, and you could say, well, that could be everything lasting from 1 second to 6 months. But then we also asked them, for how long did you have it? And there you can see that actually we have 30% of those with hip and groin pain actually have it for more than 6 weeks. So there is a lot of players who have a lot of problems for a long time. But a lot of these players, and we will see that as well, will be playing. Only 50% of those with pain will say yes to missed games. That means the other 50% will say, no, I don't miss games. I have the problem, but I don't miss games. And you can also see that those that miss games don't miss a lot of games. So even though there's quite a lot of people having problems for a long time, it doesn't affect a lot of games for them. And we also follow them from the preseason, so the history from the preseason into the new season. And you can also see that when you have this season, or in Denmark, you sort of have this is the beginning of the new season. Here you have the season break before that, and this is the information from the previous season. So this is the beginning of the new season. You can see that those who had it in the previous season, a lot of them will go through the season break and still have the same problem, even though they have been on a summer break. You can also see that a lot of them will go on, and in the beginning of the new season, they will have a different kind of problem, but in the same area. Then there will be a few of those who don't have problems that will develop problems. And then again, you can see there's also quite a few of those who didn't have the problem won't have the problem in the new season. So this again just shows that giving these people a summer break doesn't change their return to play, doesn't return their status. They still have the problem, and they're still playing, many of them. And you can see at the beginning of the new season, 36% would say they have problems, whereas 64% will say they don't have problems. Then we also looked at the hip and this HAGOS, which is hip and groin outcome score, and it's similar to KOS in the way that you have this 0 to 100 score, and 0 is very bad and 100 is perfect, and it's combined by a lot of questions, and you have different sub-categories, and here you have something related to pain, something to symptoms, something to daily activities, something to sport, and something actually to your ability to participate at your desired level and quality of life. And what you can see is that the longer they said they had problems in the previous season, the worse off they are in the beginning of the new season. So again, just highlighting that they go into the new season, a lot of them are playing, but they have, you can say, severe problems, a lot of them, and you can see that in the HAGOS. And this has never been showed and doesn't come in the normal sort of classical injury statistics. But I guess most of you will probably recognize this if you work with these players. And this is sort of the reference line for injury-free players. So if you're above this level, you could say you're in the 95%, and you can see that those players who actually have it for a long time, they would be below this level. Then if you come into our clinic, and we see quite a lot of players or athletes in general with this problem, often they would have even worse problems and a worse score. So that would be sort of a mean I just put in for these players. If you have an adductor-related problem, if you have a joint-related problem, your score would be even lower. So you can see there seems to be almost a dose-response relationship in relation to how long you had it, but you can also see that it seems that having hip-related problems will make you more severe and give you a sort of a worse score. Then I will touch upon adductor-related groin pain because that's probably the groin injury we know the most about. And this is from the Doha consensus, where we also were able to sort of create consensus on using different terminology for specific anatomical sites where the pain is originating from. And I will not talk a lot about this because I know my good friend Tim Tyler will go more into detail about this study, but this was an RCT published in The Lancet where we showed that, or my supervisor in my PhD and my boss, Per Hølbig, showed that if you do an active program, it's much better at getting people back actually to play without symptoms. So that he had criteria not only for getting people back, but also for getting people back with groin pain, but with no problems in relation to sport, with no problems in relation to aggravating activities such as squeeze testing and so forth. And this is the program. So now you have the program in the back of the mind. It's quite intense and goes on for quite a long time. And you can sort of just remember that when Tim goes more into detail about this program. And it has this sort of build-up where you actually start by facilitating muscle activity, and then you go into more coordination, and it becomes more sport-specific. Now you know a little bit about the program, because now there will come some data where this study is also included in, and then I will make a few points about that and how these players or these athletes, there was a lot of soccer players in that study, are actually doing in relation to other studies. So this is a new systematic review that came out just this year. And I think the best thing to be said about this study is that it has a lot of athletes going through surgical treatment. You can see, unfortunately, not so many go through rehabilitation. But so the numbers on surgical treatment in males, not in females, in males is quite good. The sad thing is that the level of evidence is very low, and especially if you go to the surgery studies, the level of evidence for those studies would be at level 4. Most of them are case series and not that high level of evidence. And we also know that the lower the level of evidence, typically the better the result is in relation to the outcome. So there's a bias there that you have to keep in mind. Here they looked at the different sort of, not the entities, but they're still very close, trying to put them into different regions. And I think I'm not going to comment too much about that, but the main thing here is, because you can see that some of the groups, there are very few people, so you have to be very careful with these statistics. But you can see here, which is very common, is that the return to play rates are very, very high. So no matter what you do, these people will return to play. There are very few will not return to play. And that was my point in the first place. And so is that really a good measure of how well you will do after surgery or after rehabilitation? You can also see here that if you look at the surgical versus the physical therapy rehabilitation, you can see that this is the surgical summary, and you can see there's quite a lot of variation, and these are also different techniques. And it takes quite a long time to get back. This is weeks, so 13 weeks. What I find, I think that's probably the main message in this, that it takes a long time if you get surgery in this region. There's another thing you need to look at, and that is there are some studies who actually suggest that you can get back very, very quickly after surgery with somebody who's got really severe problems. This is down to 2 weeks. This is a famous surgeon from Munich. And you can just see that that is completely, these procedures have a completely different return to play time compared to the others. So if you get into this surgeon, they will get back in 2 weeks. But I don't know what the level of their outcome will be. No one knows. I think that's the main problem. See if we can get that. And here's the summary of the rehabilitation, and you would see the same. So again, the fewer patients you have and the lower level of evidence you get, you will see the shorter you can get them back. So again, just be careful with those studies that say they could get their athletes get back really quickly, because most of them are really low level of evidence and the quality is not that good. Here we have the Per Hölmich study, and you can see that that's actually on this side. So this is usually what we tell patients when they come in with a long-standing problem, that you should think about almost 16 to 18 weeks before you actually will be able to get back into play. And again, there's somebody would suggest that you can go back within a few weeks. So again, I'm just saying, yes, you can go back, but what does it say? Nothing to me, really. And you can also see that, again, the average is not different from the surgical. So again, the main point is that if you have a long-standing problem, whether you're going to do surgery or you're going to do rehabilitation, it's going to take you a long time to get back. So you might want to start up with the least invasive, sometimes I even hear the argument the other way around, that when you cannot persuade people to do rehabilitation that takes a long time, then some people say, well, let's get him to surgery, because then we can actually keep this guy out for the period he needs. Which is, just think about that argument. It's really, but it's probably realities in some places. Now we will get him surgery because then we can control him. It's not necessary. You can do just as well with rehabilitation, but it's no miracle cure. And if it is, it's probably a low-level study, and it's probably a shame. I will not talk about these acute injuries because Tim will allude to this. Just again, in relation to what actually Ian was talking about, here is a different perspective. So this guy had, on both sides, in different times, he had an adductor complete tear of his adductor longus. When we did an ultrasound, and there was a year between those, the ultrasound showed the same, complete rupture. So from a doctor's perspective, they would give specific recommendations on when this guy could be back, because he had a complete rupture. But when you then let the physio come in with a program, you can see that and this physio was me, then you can see that even though they have sort of similar return to play, there was a difference here between 3 weeks. This is a case study. But just to say, they were not that different, and they also, but there was one of them taking a little bit longer. But when you then look at the strength, they were very, very different. So the first injury actually took 1 year to get back to 100%, whereas the other one took only around 10 weeks. So something that looks structurally very similar can be really completely different. And again, if you look at this with the ultrasound, you might make a different decision from when you're actually using a strength measure. So again, it depends on also, it's not just your, your shared decision making would be influenced by your reference point as well. And what we sort of recommend is that we want to get people up into this area of 80 to 100%. Tim will talk more about that. And we also suggested that when you have these players that have been out for a long time, the main measure that I can actually say something about when you are back to 100% in strength is your eccentric measures. That's where you get your deficit between players with problems and asymptomatic players where we cannot find any difference in the isometric measures. This does not go for the acute injuries. This is something we find in the long-standing injuries. So we often, when we come into this region, try to introduce isometric measures up to here, but here we definitely want to include eccentric measures to get something that is more provocative and probably a better measure of their capacity in relation to what they are about to go back to, but also in relation to what makes them different from those who don't have problems. And it seems that this 20% comes up, and I think Tim will talk more about that. He's got it as a ratio, but around 20% deficit, then you're sort of heading for trouble. And we're starting a big study in aspartar, and we've gathered the data already, but Andrea Mosler has a lot of data where you can actually plot the data also on the absolute values to see when do you actually start to deviate from the standard deviation, and we can try to map to see if this will increase your risk of injury in relation to your strength measure. And our theory is that if you are here down in the low side, you will probably have an increased risk, but we will know more about that. Then there's also a little bit of data on the abdominals, and we know from the literature that there's been a lot of focus, especially from the Australians, on the core activity. So this is a study where they looked at the transversus abdominis timing in relation to erector femoris in people with groin pain. And when you don't have groin pain, you should have a pattern like this, where this TA sets in before erector femoris. And what they could show was that when you then have groin pain, you seem to sort of change the coordination of your muscles. I think in real life it becomes very, very difficult to use this kind of study for anything, because what they're actually looking at is 10 milliseconds. So 10 milliseconds would be the same it takes a hummingbird to flap its wings once. So it's not something that we can clinically actually identify and use in the clinic. It doesn't mean we shouldn't use core exercises or train that region, but it might be that there are other things that we can assess more easily, and maybe something that stares more in the face. And that, I think, is also a strength deficit. Here's a nice study from Egypt where they looked at concentric and eccentric strength in somebody with groin pain. And you can see here that, again, no deficit in concentric. They didn't do isometric, but they did concentric. And again, the deficit is huge, but it's actually an eccentric strength. So again, there's something there to address in these players. Again, this is probably not the most on-field apparatus I've seen, but again, you could be certain that many of these players will have this, and you can address it quite easily. And we need more clinical and more on-field based tests to reveal this. There are a few tests that can predict future injury that are also mainly related to strength. You can see that strength of the adductors is the one that actually increases your risk of a future groin injury. So I would definitely include that in my players and my players that are going back. We have looked at a different way of trying to address this, and it also in almost 700 players, we looked at the relationship between the Copenhagen hip and groin outcome score. And if you just ask them numerically how much pain do we have during this adduction test, so they would just rate it when they do maximum isometric adduction, how painful is that? And some would say 8, some would say 3, and some would say 5. But that's actually, this test actually quite nicely relates to the Copenhagen hip and groin sporting function. So this is a much easier way, because as I showed you this morning, most of you are not using these questionnaires anyway, because it's too long, you have to score it afterwards. So we need something that we can do just like this, and this could be a way of doing that really quickly. So basically what you do is you put your arm in, and you tell people to squeeze as hard as they can for 5 seconds, And what we then also have done is actually put the dynamometer in between. So we're not only getting a pain rating, but we also get a rating of how much force they can produce. So I think one of the ways to go in the future is that of course we want people to come down in pain, but we also want them to come up in relation to their baseline value in their MVC, so we know that the tissue can actually tolerate some of these stresses. So this could be a future tool and a future way to go also in other areas of the body. So take-home messages here are that I think that RTP is less relevant in hip and groin injured players. They are not out of play. So, I mean, it doesn't make sense to talk about return to play because they were never out of play in the first place. And that's also why I think this concept is seriously challenged when we talk about overuse nature injuries. Rehabilitation takes a long time for these, with or without surgery. So you might as well start up the rehabilitation and don't promise them any quick fix because most of those are based on poor science. And the measures of prevalence, sporting function, and severity is not surprisingly more important to me anyway, because that's what I do my research in than return to play. Thank you very much.